This COVID-19 COS project began in March, and it arose from some national work to develop living evidence to inform frontline clinicians in caring for patients with COVID-19. However, the scope of this work is global. I might just go to the next slide, please. So the aim of this project is to develop a core set of outcomes to be reported in all trials in COVID-19. So we set up a steering committee and investigators, and just to note here that patients were involved at various levels in this project. So we had patients involved on the steering committee as well as on the investigator group, and we actually employed a patient as a research assistant to be part of the core team. And also patients were involved as participants. Next slide, please. So just to begin with the quote here, most researchers are focused on the viral load, but what matters most to patients may not just be the viral load. There may be other aspects, other impacts of COVID-19 and treatment that are important to patients and clinicians. Next slide. And so the process that we followed is based on the COMET framework for developing core outcomes, which is regarded as a rigorous, systematic approach for establishing core outcomes. So these are basically 3 to 5 outcomes that are meant to be reported in all trials in a given area, and in this case, it's COVID-19. And interestingly, I looked at the WHO website, and there are about 3,200 registered trials in COVID-19, but it's a little uncertain as to whether the outcomes that are currently being reported are relevant or meaningful to patients. So what normally takes maybe 12 months at the least, we had about 4 weeks to run these 3 phases. So today I'll be presenting on the steps to develop the core outcome domains, because the next tranche of work will be to look at how to measure these core outcome domains. Next slide, please. So this is some preliminary data from our systematic review. I'll just get you to click next because there's some animations. And we looked at 182 trials registered and found that there were 70 different outcome domains reported. I know the text is a little bit small, but just to point out here, the blue outcomes are clinical outcomes such as mortality. We've got pink, the surrogate outcomes or the biochemical markers, and yellow are the patient-reported outcomes, so outcomes that reflect how patients feel and function. So the most frequently reported outcomes across all these trials were hospitalization, death, viral load. And interestingly, even though that these were the most commonly reported outcomes, they were reported in less than half of the trials. And the most frequently reported patient-reported outcomes were cough and shortness of breath, both reported in less than 10% of trials. Next slide, please. So we can see that there's lots of variability and inconsistency in the outcomes that are reported. So this is a snapshot of the results from the International Delphi survey, where we included 776 people with suspected or confirmed COVID-19 and family members, 4,882 health professionals, and 3,631 members of the general public. And this survey was launched in 5 languages: English, Chinese, in Italian, Spanish, and Portuguese. So in total, 9,289 participants from 1,111 countries. Next slide, please. And here are the results. So the participants were actually asked to rate the importance of the outcomes that were based on the systematic review and also input from patients on the grade scale, so from 1 to 9. A grading of 7 to 9 meant that that outcome was of critical importance to the respondent. So we calculated the mean scores, the median scores, and the proportion of people who rated the outcome to be critically important. So interestingly, there was actually very strong consensus across the 3 groups: the patient's caregivers, the health professionals, and the public. And the top rated outcomes, I'll just read the first 5, were death, respiratory failure, pneumonia, organ failure, and lung function. So the top rated outcomes were similar across the 3 groups. Next slide. But then we also plotted the mean difference, and I know the text is a little bit small, but the outcomes where you see the red dot on the right, these were favoured by patients family members compared with health professionals. And just to point out here, it was interesting when we looked at this, we found that patients and family members gave higher priority to many patient-reported outcomes when compared with health professionals. So, for example, fatigue, muscle pain, gastrointestinal problems, anxiety were rated higher by the patients and family members. And we did also look at not only the scores, but the qualitative data, which also indicated that the higher prioritization of the impact on family, depression, anxiety, it did reflect a lot of the angst about isolation, and also patients talked about the guilt of infecting others or potentially infecting others. Next slide. So we're looking at these results, we put forward a proposed set of core outcomes, which we discussed at an international consensus workshop. So we ran 4 workshops in mid-April this year, and in total we had 95 attendees from 21 countries. Of those attendees, around 20 had lived experience of COVID-19. Next slide, please. So just to summarize what emerged from the discussion, we identified 6 themes. So one was around the responding to the immediate crisis. Participants noted that the top-ranked outcomes really reflected kind of this response to the crisis of COVID-19, which is why mortality and respiratory failure, multi-organ failure were prioritised highly. They also noted that there was a need to capture different care environments because participants with COVID-19 could be receiving care in hospital, but also in community settings. So the core outcomes had to be relevant across these settings. They also noted that it needed to encompass the spectrum of disease severity and trajectory. A lot of the top prioritised outcomes were very focused on kind of the critical acute phase of COVID-19, but they also said that we really do also need to focus on people who may have less severe disease or are recovering. They need to distinguish overlap and collinearity of outcomes, recognising that adverse events may occur, and being aware of family and psychosocial well-being. I'll just get you to click next to show a couple of quotations from these workshops. One patient said, "I was in hospital briefly, but not hospitalised per se. Multi-organ failure and sepsis weren't an issue for me, but the shortness of breath, the breathing issues were." Next. It's about ability to function afterwards. What is worrying me now is post-viral fatigue and recovery, because it's been a very long time since I've spent 2 weeks in bed and I'm showing no signs of being strong enough to even function in the house, never mind go back to work. And that's what's concerning me about a long-term recovery, is that kind of post-viral thing. Next slide. And so based on these workshop discussions we summarised, we sent out the report to all the attendees and also the investigators. And the core outcome set includes mortality, respiratory failure, multi-organ failure, shortness of breath, and recovery. So I might stop there. And now we're actually doing ongoing work to look at developing the core outcome measure for each of these outcomes. Thank you so much.